So, good morning and welcome to the November Equip meeting. We're going to call the meeting to order again. If you did not get the slides from me about 15 minutes ago, we'll check your spam. And then after you check your spam, if you still don't have the slides, throw your email in the chat and I'm going to make sure you're on the list, and I'm going to send the slides to you while the meeting's going on, so you have them and you'll have them for future use. And I just want to remind everybody that two great places to go and get information. We have a question about Equip is the CRISP website. They have a whole section on it. And then our website, and we are hosting all the videos of these meetings. And then we also have some other videos of some of the explanations that were specially based. So like we have a really good slide presentation with Dr. Pines on the ER episode, and then we have others where we were doing outreach around some of the other episodes. So if you have if you're in a bigger hospital system and you want to make sure that you have a group of physicians who want to understand what they're doing or why they're doing it, it's great to go watch those older videos. You can see some of the questions that get asked and things like that. The other thing I'd ask everybody to do is to please share those the Prometheus grouper episodes out with practices. Will and Jessica and I are working on what we're going to be considering adding for next year. We've had some meetings with some renal docs about possibly doing an episode around that would be outside of the grouper. But if there are any episodes in that grouper, if you would like to share it with share them with the physicians in your group and those specialties and say, hey, do any of these make sense? That would be very helpful to us. We're very open to adding additional codes free from that group. So having said that, am I turning it over to you, Will, or Jessica? Who's kicking it off this morning?
I believe I am starting.
You are starting. Well, I will stop talking then and turn off my screen and turn it over to you, Jessica. It's all yours.
Sounds good. Thanks, Jean. So today I will start us off and we're kind of going to go over administrative and enrollment updates. A lot of this will be about sort of the next steps that are happening in these last months of the calendar year. Will is then going to do an overview of performance year 1 data, which is now available in the portal. And then, as Jean mentioned, we're going to talk a little bit about episode development for performance year 3. So all over the place. So performance year 2, so where we are in this enrollment process, we're in this November, December timeframe, which is all about sort of care partner arrangement, signatures, and ensuring we have everything executed properly for the beginning of the next performance year on January 1st. Just as a little update, as of today, we have about just over 3,500 care partners that are enrolled. We did expect a big drop sort of after the initial enrollment. We're still about 1,200 more than we had last year, if not even more than that. So a big jump of growth, which we're excited about. We still have representation from all 43 different specialties. And then of the 45 episodes that are available, we have at least one entity that's participating in each one of them, and with a total of 68 different entities. So again, we're super happy about that growth. As we know, we always caveat sort of our numbers with that the final participation is not determined until January 1st when we have those executed care partner arrangements, as well as the final vetting status from CMS. So through the end of this year, we're going to work on those two things, CMS and the contracting. Okay, so what has happened over the past couple weeks? So we did receive the initial CMS vetting results and they were posted into EAP. This really only impacted about 25 care partners who did not pass vetting, and every entity that did not have a care partner pass was emailed individually. So you should have those names, but it is updated in and posted into the Equip portal as well. There's one sort of last round of vetting, which is the program integrity and law enforcement. And we sort of expect that to be returned back really late of this calendar year, probably bumping up close to December 31st. But the impact is very, very small. I think last year we had like one physician that was impacted. So really, we do not expect that to be a huge impact, but of course we caveat the eligibility based off of that final results coming back. Additionally, care partner arrangements were distributed, I guess, last week, the 10th. So an email was sent to the lead care partners and administrative proxies with a link to access a shared folder that was created for your entity. Within that folder, you are able to download all of the care partner arrangement PDFs for your entity. And really what we're doing here is kind of relying on you guys, so the lead care partners and administrative proxies, relying on you guys to disseminate those arrangements and obtain the signatures back from the individual docs. We do need them signed back prior to December 31st. And as a reminder, please do not upload them into the shared folder. We ask that you send them to the equip@umm.edu email address. Also, just a note, our preference on our side is that instead of you all holding them until you have your entire entity and batching the emails, we do request that you send them as you get them in. It helps us with ensuring that there's not a backlog on the processing on side as well. So we would appreciate that if you're able to do that. And then as a reminder, only new providers or those who change entities will be required to sign a new care partner arrangement for performance year 2. The performance year 1 providers who remain with the same entity do not need to re-sign, and their participation is automatically renewed. And you'll notice that there was not a care partner arrangement created for them in that folder that you now have access to. So let's talk about renewal, because we do want to emphasize this. As we mentioned, the renewal is automatic for subsequent measurement periods. So that includes this next performance year. And we really, again, relying on you guys to ensure that the correct providers are registered under your entity. And you can confirm that by going into the eQuip Care Partner dashboard and see a list of names. And if there is a care partner who is no longer enrolled with your entity, or that care partner wishes not to participate, please send the equip@chrishealth.org an email prior to the 31st, or else they will automatically enroll. And we have gotten a couple of retirement announcements. And again, that care partner will remain active through this performance year, but will no longer participate or will not automatically renew for the next performance year. So care partner arrangement status. This will be updated weekly for you all to see, again, what care partner arrangements we have executed within our system. And to do this, we're just reminding you to log into EAP, and you can navigate to this care partner dashboard. I apologize, it's sort of small, but it's under the program management tab. And if you reference the column over here that's called care partner arrangement status, you'll be able to see their status. So for right now, there are existing care partners that are listed as signed, and those are those care partners that have a care partner arrangement on file for us for last year. If there is no arrangement on file, that line will be left blank, and those are the physicians that need to sign in order to participate in performance year 2. And as a reminder, this will be updated weekly, in addition to weekly emails to you guys to ensure that you're kept abreast of the status of your different doctors that are participating. So that's all for the announcements, sort of enrollment. If there are any questions related to that, I want to give a little time there, but of course, always we have that eQuip inbox for any sort of questions or concerns related to that. And this is just a little bit reminder about timeline where we are right now. Okay, I'm not hearing any questions. So Will, I'm going to hand it over to you.
Fantastic. Thank you, Jessica. Next slide, please. So we have updated the eQuip portal with the first quarter of data, so participants can start seeing how they're performing. As a reminder, this is only episodes ending in the first quarter of the performance year. It does not indicate the complete performance period. And we really strongly caution people against over-interpreting what could be a small number of data points. When we, working with the commission, look at our statewide waiver test, we really don't start placing any weight on where we are on the waiver test in a given year until we have about 6 months of data, because small samples can be very volatile. So we very much encourage people to start looking at the data, getting comfortable with doing analytics on it, but not to overreact to the first quarter's worth of data. You can see this data through the eQuip portal. And if you go to the next slide, Jessica. So you can see either performance and savings summaries by clicking on the circled blue card here. This will show a summary of eQuip entity performance. And if you have PHI access to your eQuip entity, you can see more detailed data by clicking on the performance dashboard. We're going to walk through an overview of the data and the reports that are available, but there will be a report done by CRISP that will go into much more detail. That will happen sometime in, I think, early December. Next slide, please. So the performance period, the eQuip performance summary, this will show a summary of eQuip entities and the number of episodes that they've initiated, the total payments, the preliminary target price. And by comparing those two numbers, the preliminary target price and the total payments, you can get an idea of how each eQuip entity is doing in each individual episode. This is not the actual reconciliation amount, so a couple of things have not been applied. Here, this does not apply the minimum savings rates, it does not apply the quality adjustments, and it does not apply the shared savings percentage. So this is not technically a reconciliation payment, but it does give you an idea of how everyone in eQuip is doing on each one of those episodes. Next slide, please. So this is in the performance dashboard. Again, this requires PHI access, but this walks through individual reports for each of the eQuip entities. So a quick note, I'm showing you dummy data here. So first, there's no PHI, no reason to report me to the HIPAA. But also, this is not going to be, this is dummy data. So don't read too much into any one of these numbers. They may or may not make sense. This is only to illustrate the data that's available to you guys. So the first report that's available is the target pricing summary. This shows you the target pricing both for each episode that you're participating in and the target price by dates, by place of service, ambulatory surgical center, inpatient hospital, et cetera. You can choose to look at an individual care partner or an individual episode if you want. So using those drop-down options at the top, the attributed care partner and the episode, you can restrict to look at either an individual episode or an individual care partner. But this overall summary will give you the average target price across all of your episodes for the eQuip entity. Next slide, please. So, sorry, is there a question?
I have a question. This is Lauren McDevitt. Are we throwing out the lowest and highest outliers? You know how nationally, when you have bundle payments, there's like that 5% and 95%. Are we throwing any out with those sort of parameters?
Yes, so there is Windsorization here. And we can walk through that or talk through that either at the webinar, or if you want to reach out to us directly, we can talk through that.
I just wanted to know that we were doing that, what the percentages were. That's all. Thank you.
Yep, great. So this place of service report, this shows the average cost and the number of episodes by place of service and by first post-trigger setting. You can see the trigger or the episode cost by place of service at the top, and then the first post-trigger setting at the bottom. A couple of things that are important to know about this, particularly the post-trigger setting. This is the first setting after the trigger that we have a Medicare claim for. And that distinction is very important because it may or may not align with what you see in the medical record. As an example, if you discharge a patient from the hospital to a skilled nursing facility, you will see that as a skilled nursing facility as the first post-trigger setting. If you discharge that patient to skilled nursing that is in an inpatient setting and billed for under an inpatient under IPPS or OPPS or as a hospital service, you will see that show up as inpatient hospital, even though the service the patient is receiving is in fact skilled nursing. So the trick with interpreting this post trigger setting of care is that we are only able to report that as we see it in the claims, and the claims are very literal, right? So, skilled nursing facility means a skilled nursing facility under the Medicare claims. An inpatient hospital means an inpatient hospital under the Medicare claims, even if they're receiving sort of similar types of rehabilitation. And so, I think this can be very useful for people. Obviously, if you're trying to, create more efficiency by managing post-acute care or post-trigger care. But it's important to note that, that this sometimes there will be a misalignment with what's in the medical record and the discharge status on the medical record. And then at the bottom, you can see obviously the average cost of the episode by first post-acute care setting. And this is intended to give you an indication of where there are potential savings by post-acute care setting. Next slide, please. So the sequence of care report, this is an interesting one. This basically takes all of the episodes and shows you the frequency of episodes by setting of care, not just the first setting of care, but the entire sequence of setting of care. So the inpatient hospital one, if you look at that, the first row under inpatient hospital here, it says AC, you have 19 episodes there. That means that you've gone to from the acute care setting to the community, right? So this is a discharge to home.
Will, Renee has her hand up. So
I'm sorry. Go ahead, Renee.
Hi. Well, going back to the last slide, can you speak a little bit more to where it says the first post trigger setting? I didn't quite understand, for example, with the community, what's the difference between the average total cost, the average total episode cost, and the average pre-trigger amount, the average trigger amount, and the average post-trigger amount? What are those triggers in terms of the first post-trigger setting?
So good question. So the total episode cost is all the cost that's included in the episode. The trigger cost is the cost of the episode of the event that starts the episode. So if it's triggered in a hospital, it's the cost of that hospitalization. If it's triggered in an outpatient hospital department, it's the cost of that outpatient hospital visit. Now, the Prometheus episodes include some costs for some of the episodes. This will vary by episode, but they include some costs that occur prior to the triggering event. And so that's what's indicated in the pre-trigger amount. Any costs that are incurred prior to the trigger of the episode. And then anything that's the post-trigger cost is anything that happens after that triggering event. So it basically divvies up this episode according to cost before, cost in the triggering event, and cost after the triggering event. Does that help, Renee?
Okay, so for when someone's discharged to a skilled nursing facility, the trigger amount is the cost of the skilled nursing facility stay?
No, I think here the trigger amount is always going to be this setting of care. So if it's triggered in an outpatient hospital department, you should see that cost in the average triggering amount. The skilled nursing facility is likely to show up as a post-trigger cost.
Right. So and that's what confuses me. So I mean, on the top there, trigger place of service totally makes sense. That right. The triggering episode, for example, on the on-campus outpatient triggering amount $14,000. That's the cost of the triggering procedure. But I'm confused by the difference down below.
Yeah, so again, this is just dividing up the episodes by first setting of care after the triggering event. The trigger, though, is still the same event in both settings. And I think the way that this is useful is if you look at the inpatient hospital and the skilled nursing facility rows here, you can see, I think, a very clear pattern, right? A patient who is their first post-trigger setting is an inpatient hospital. They had a pretty low average trigger amount, right? $18,000, but then a pretty high average post-trigger amount. So what this probably means is that that patient was admitted to the hospital, had either a readmission or went to the ASC and then came back to the hospital potentially for some complication. Indicates that, you know, people who went to the hospital immediately after the trigger, you know, the trigger event itself may have been cheaper, but there were a lot of post-acute care costs, right? Post-trigger costs. And so that probably indicates, you know, that some complication occurred, you know, potentially as a result of what happened in the episode. In the skilled nursing facility, on the other hand, that has slightly higher trigger costs, but it means that, but there's also lower post-trigger costs. And so my interpretation there would be this meant more time was spent in the triggering setting, right? And, you know, there were some skilled nursing facility costs, but that potentially avoided an expensive inpatient hospitalization or a readmission, et cetera, after the triggering event. Does that make sense, Renee?
Yeah, it does. Okay, thank you.
This is Lauren McDevitt again. Along those lines, when you look at the first post trigger for community and there's a cost, is that cost the bounce back to the ED since we sent them home without anything? Is that what that cost is? That average post trigger amount?
So it potentially could be an ED visit. It could also be, you know, so this is just all costs that happen after post trigger. So this could be somebody who's discharged to their home and, you know, they have a couple of follow-up visits, maybe with their primary care doctor or their specialist. It's not necessarily an ED visit. It's just everything that happens after the discharge or the trigger. Yeah. Kendra?
Yeah, I have a question about the pre-trigger amount. So we have some of our surgeons with extremely high, like 30,000 up to 60,000 in some cases. I'm assuming, and I can't tell from the data, that maybe it was a fracture that they were consulted on and did a total hip replacement or something like that. But is there a way that we're able to see a breakdown of what those pre-trigger costs were and why it's so expensive?
Yeah, so that's not going to be available in our eQuip entity portal. That probably is available through the DEX individual claims. So you should be able to get all claims associated with the episode through the DEX, and you could then see what costs occurred pre-trigger.
Yeah, so when I did pull the DEX, and it's just the only thing they give as far as pre-trigger amount is split and unsplit costs, but it's not specifically what that pre-trigger was attributed to.
Right. So are you looking at the episode summary or the claims extract?
I believe the episode summary.
Yeah, so the episode summary doesn't go into, you know, it does not have the individual claims, but we do make that available through DEX. You know, there will be a little bit more analytic work, you know, analyzing those claims data to figure out what those pre-trigger costs are. It is available, and we can cover how to look at those claims data in the webinar that we're holding in December.
Okay, sounds good. Thank you.
Great. Any other questions? Wonderful. Next slide, please. So as we're talking about the sequence of care report, this shows, you know, anybody discharged to the community. You can see under the trigger place of service, ambulatory surgical center has a lot of people going from the ASC to the community. You know, a couple of people going to the ASC to the community, then back to the hospital, and so on and so forth. You know, this report, I think, can give you a sense of where your most frequent patterns of care are. And you'll see, you know, and could identify where, say, the hospital shows up either as a readmissions or an event following the hospitalization. Next slide, please. So this provider comparison tool, this allows you to compare your care partners and episodes associated with those care partners to the overall average of your entire eQuip entity. So you can see who is doing well and who is doing poorly, or get a better sense of patterns of care from at the individual physician level. There are a couple of different views that you can see. You can see trigger place of service, first post-acute care trigger setting, et cetera. And so this would give you a sense of, which of your physicians attribute or trigger episodes in the hospital versus the ASC, and what happens immediately after there. Next slide, please.
Will, there's a question in the chat. In the portal, are we able to see who the numerators and denominator patients are, their names, ?
Yeah, so I believe in the DEX data, they're currently, we do not include their names. We just have an identifier. I think we are planning to change that. And so we would allow people to link back to the medical record. I think we've just been a little cautious with, sending out people's names and identifying information. But I think a number of physicians, providers have indicated that would be extremely valuable. So we are planning to add that as an enhancement, and it should be available by the time there is a subsequent data update. Okay. So this is another view of post-trigger hospitalizations. When we look at these episodes, we see a lot of the costs are driven by whether there's a readmission or not in the context of an episode. And of course, by readmission, that only occurs if the triggering place is in an acute care hospital. But so if the first event following the post-trigger setting is in a hospital, that tends to drive a significant amount of the costs. So we've shown a breakdown of the number of episodes that have a post-trigger hospitalization, both by setting of care and by individual physicians. So you can see which physicians are driving that post-trigger hospitalization rate, and then what the pattern is based on discharge setting. Next slide, please. We've done the same thing. So the previous view shows this post-trigger hospitalizations across all providers. This shows post-trigger hospitalizations across all clinical episodes, although you could see the triggering event by provider and by episode name by using the episode drop-down menu at the top of this. So it's eQuip entity, attributed care partner, episode name. So you can see here, for an individual care partner, how many of each one of their episode types goes to the hospital post-trigger. And on the previous tool, you could see for an individual care partner, which one of their episodes resulted in a post-trigger hospitalization. So two different views trying to get at the same thing. Next slide, please. So here we've shown the potentially avoidable episode complications and the number that occur within each one of the episodes. We have gotten a number of comments from folks seeing that this in particular would be helpful to link back to the patients. So you could do a chart review or see what sort of episode complication occurred. So that's another enhancement that we're going to be adding to the DEX file. It's not available yet, but should be available soon. So this view, though, is just the summary view. That enhancement will show up in the DEX, but this gives you an idea of how many episodes and the rate at which the potentially avoidable episode complications occur for your episodes. Next slide, please. So this is the quality score. This shows you how you're doing on each one of those quality measures that we put into the eQuip program. This shows you your advanced care performance rate, your BMI performance rate, and your medication reconciliation performance rate, and the way that that's combined into the composite quality score. It also indicates whether or not you're on what we call probation, right, which is that quality score is too low, and potentially, you would lose eligibility if that quality score does not come up. This view actually shows all EQUIP entities, and so you can see yourself versus the rest of the EQUIP participants. If you go to the next slide, please. And then this slide shows for each one of your care partners, it shows the number of episodes that they have and the advanced care measure rate, medications measure rate, and the BMI measure rate. So you can see which participants in your EQUIP entity are driving either success or a poor performance under that quality measure. Next slide, please. And I'm sorry, I think I saw a question.
So Kendra in the chat said, is the composite quality score the percentile that we are currently in?
No, it is a translation of that percentile. So it's not the direct percentile, but it is a relative measure of your performance compared to the rest of the state. And if you want more details on how that quality score is calculated, please feel free to email us and we can send you those details.
And then Brian has his hand up.
Hey, Brian.
Hey, so I have a question about providers who are on probation and what occurs if they don't increase their numbers to reach that threshold for the next year. I guess my main question is, during that probation year, are we still assessed on their performance for that year if they're going to be removed from the EQUIP program for the next year?
Yes.
Okay.
And Will, correct me if I'm wrong, but I think the way quality is your entity is on probation, not individual physicians. So this breakdown will be able to show if one physician is driving, the score up or down, but like we won't make a individual physician ineligible based off of their quality. It's the entity in composite that is put on probation.
Yes.
Okay. Is that the same with the cost?
Yes.
Okay.
Yes.
Thank
The
you.
only individual physician probation has to do if they did not touch a claim in this, now it's baseline. If they did not touch a claim in baseline and they also do not touch a claim in PY1, they'll not be eligible for PY2 because essentially they have no relationship to the episodes. That is
Right.
the only thing at the individual physician level. Everything else from a probation status is at an entity level.
Gotcha.
Sorry
Thank
for
you.
that confusion.
That's all right. Thank you.
Okay, thank you. Any other questions on this? Wonderful. In that case, this last sheet shows the calculation of the EQUIP shared savings payments. This does include all of the individual adjustments that are made. So the quality score adjustment, the shared savings percentile, and the minimum savings threshold. So just as a reminder, your savings must exceed the minimum savings threshold before you receive a payment. And then we apply for any difference between the aggregate target price and the aggregate episode payment. We apply the shared savings percentage based on your relative level of cost in the baseline period. So if you're in the first tercile, it's 50-50 split with Medicare. Second tercile, 75 to you, 35 to Medicare. And in the third tercile, it's 80% to you, 20% to Medicare. So that percentile is multiplied by any savings after you exceed the minimum savings threshold. There's also the quality adjustment, which is there's a slight withhold from the incentive payments that are made to the physicians based on your quality score. And that is relatively small, but we've included the calculation here so you can see your final expected payments. Okay, next slide, please. Okay, so a couple of things. First, more data is available through DEX, and we will include a summary of DEX in the webinar that we do in December. But DEX includes two things. First, it includes summary data on each individual episode. So here we've aggregated everything for you. If you want to drive into a particular episode, you can see the summary data on that individual episode. You can also see all claims level detail on each episode, and that would allow you to dive into what setting of care, what individual physicians, et cetera, are driving costs within the individual episode. I mentioned a couple of times we'll be holding a webinar to walk through both the eQuip portal and the DEX files, and that'll go into more detail than I have in this meeting for all of the data nerds out there. And then as a reminder, additional data is added to the eQuip portal on a quarterly basis. This includes the first quarters of data only, and we would expect additional data to start being added in January and then quarterly from there on out. So are there any questions on this data availability that I can answer now?
I have a couple of questions. Are we able to see hospital rate transparency? I know that I sent you some data over, Will, on our inpatient versus outpatient triggers, and that our outpatient triggers, for the most part, are higher than our inpatient triggers, which seems to be a little backwards. And so if we're trying to make change with our physicians to not have dis savings in the program, we don't know how to do that if we don't know where our hospital rates are for the current year.
Yeah, so all hospital rates that the HSCRC sets are available on the HSCRC website. And so you can see the cost per rate center for all hospitals in the state of Maryland.
Doesn't help us, Will.
Would you be able to provide the link to that? And is it per DRG or per Prometheus group, or how does that work?
Right. So in Maryland, hospital services are paid on a rate center basis, not on a DRG basis. And so there's a literal cost per operating room minute. There's then a cost per day in the hospital, a cost per medical surgical day, et cetera. And so to determine how much an individual episode cost, you would have to sum up all of the individual rate center utilizations in order to determine how much an individual service costs. And so there is no DRG payment in Maryland. We are considering and working on doing some, average cost by hospital for each one of the Prometheus episodes. And so we may be able to make that data available shortly, and that could give you a heuristic for that. But for an individual episode, there is no DRG rate. You have to add up all the individual rate center utilizations.
Okay, the average rate would definitely be helpful for us to know what we should do as far as inpatient versus outpatient type situations. And then the other question I had was the typical with complications and the potentially avoidable episode complications. I think I read somewhere that those merit review or something like that. So are those typical with complication costs currently included in this data that we're seeing, or are those separate?
Yeah, so I think this is going to be available in the DEX level data, the claims level data. So it's not available in this. It's not available in the summary, the episode summary, but is available in the DEX data, and you can see which complications are assigned to which episode there. Again, as a reminder, we currently just have the summary identified by, basically our internal identifier. We are going to be adding data that will allow you to link it back to the medical record in order to do chart reviews or other sorts of reviews on those episodes. Any other questions? Okay, wonderful. In that case, I want to spend a couple of minutes talking about our performance year 3 episode development. Go to the next slide, please, Jessica. So as a reminder, we're currently soliciting stakeholder input into episodes of interest. We're then going to develop an analytical plan to add additional episodes for year 3. Over the winter, we're going to be programming that, getting CMMI approval, et cetera. And starting in late spring of 23, we'll start recruiting additional physicians to participate in those episodes. And then in July and August, the eQuip portal will open for enrollment. Next slide, please. We are asking for potential participants or current participants to give us suggestions on which episodes we will be adding. We will need, if a stakeholder wants to develop, an ad hoc episode, we'll need a couple of things from the stakeholder.
Hold on.
We'll need.
Texting me, but I got it. What you need, Mama? I was.
Hey, would you guys mind please muting yourself if you're?
I got it, Will.
Thank you. Okay, so if stakeholders could provide a list of triggering procedures or diagnoses and then included costs for the episode of care, then we'll be able to build an episode for you. We are relying on stakeholders to come up with those triggering procedures and diagnoses and those included costs. The idea being we want to take advantage of all the wonderful clinical expertise that we have available in the state of Maryland. We at the HSCRC are not doctors, and so don't know, what is appropriate necessarily to include or exclude from an individual episode. We are committed to working with all stakeholders, but we do have some limited bandwidth. So we anticipate being able to add 1 to 2 new ad hoc episodes per year. And we will prioritize those based on the number of interested physicians. So basically it's first come, first serve, but if there's a lot of you, that we'll do it democratically. And if there's a lot of potential interest in one episode, we'll prioritize that area.
And just for clarification, Will, what you mean would be 1 or 2 new non-Prometheus episodes per year. And one of the things I wanted to do was just really ask everybody to share with their clinical partners the full list of the Prometheus episodes, so we can see if any of those really make sense to add, because it's very easy for us to add the Prometheus pre-packaged code. So sharing them, by type with your clinical partners could be very valuable to us. I think Will and Jessica and I have really tried over the last 18 months to share that with as many physicians and others as possible, but we're not perfect. We're not infallible, and we could have missed some that might make sense to add. So let's not miss the easy one. Let's get those out. And if there's something on there that you really would like to see added, that's easy for us to do. Correct, Will?
Yep, absolutely. So next slide, please. So these are the list of episodes that we're considering adding for the following year. We've had a number of stakeholders suggest additional Prometheus episodes. As mentioned, that's relatively easy for us to do, so we anticipate being able to add those. We just have to kick the tires a little bit. We've had some people express interest in oncology episodes. Oncology episodes tend to be very complex. So we are working on assessing whether the Prometheus logic is sufficient for the capturing oncology episodes correctly. And if those episodes are good and they do work, then we'll add them. But potentially there's more work that we need to do there before adding some oncology episodes. We have been working on some episodes around chronic kidney disease or end-stage renal disease that we potentially could include. This is an ad hoc episode that we're pretty excited about, and we'll share more details with this group as we get them and as we work with the nephrologists who are proposing this. We are also working on potentially including some behavioral health episodes. This, I think, is a very important area where we haven't done a lot of work to date, though we are encountering some regulatory and data issues around 42 CFR and our ability to share data and thus trigger episodes. So while we are working on that, we're trying to overcome some challenges there. Aside from those areas, we'd be happy to discuss additional episodes. We really do need to begin those discussions prior to the end of this year. So please reach out to us and let us know if you're interested in, if you have an idea and you're interested in developing an episode. We do need to get started in order to make sure that they're available for PY24.
And Will, we have a question from Dr. Pines in the chat. The Prometheus episode require a password. It's difficult to fully assess them. Can someone provide, I guess, I don't know that we can provide the password out. Is there a way we can provide additional detail on any of the episodes, or how would we do that, Will?
Yep. So if you reach out to us, and I know you've done so already, Dr. Pines, and I'm have been a little delinquent in getting you those episode definitions, so I'll do that as soon as I can. Please reach out to us, and we'll be happy to pass along the codes and the Prometheus definitions for those episodes. Unfortunately, I think Change Healthcare, who runs Prometheus, would get very grumpy with us if we sent out a password to the entire state of Maryland.
I think Melanie has a question.
Jean, do you mind if I just do a quick couple minutes on the CTO program? Is that okay?
No problem at all.
Okay, so many of you know me. I'm Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. And I just wanted to take a minute and go over to a program that we have in partnership with the MedChi CTO to help practices develop those skills to be successful in value-based programs. We currently have a round one that's been very successful with a variety of specialties. We do include primary care. The only practices that are not eligible are practices that are currently in MDPCP, but it is based on CMS materials, and it does help people to be successful in these value-based programs like you guys are participating in now. So if anyone's interested, they can contact Jean or myself, and we are allowing enrollment through the end of November. So thank you for giving me a couple minutes on that, Jean.
All right, Nikki McCann.
Thanks, Jean. I think the behavioral health episode sounds very promising. And I think where it really has promise is, I think, generally speaking, when you look at individuals who are suffering from mental health or substance use disorder, they have high somatic costs, right? Their physical health care costs tend to be more expensive. And I just think it'd be really exciting to pull a group of people together and really think about what could that episode look like beyond just the behavioral health episode, and could we look at it over a longer period of time instead of year over year? I just know from my experience for the Medicaid program, when substance use services were under the managed care organizations, for priority partners, when we would look at our members who were engaged in substance use treatment, they usually had an MLR of about 165%. And about 20% of that was related to their treatment of their substance use disorder, but the majority of the cost was related to physical care. So I do think that'd be a really exciting thing to explore. Obviously, that's probably something that you'd look at over a longer trajectory of time, in thinking about maybe how we could more aggressively treat behavioral health to bring down overall savings beyond just the behavioral health.
I couldn't agree with you more on that. And maybe you and I can talk offline about getting some people together from, the Maryland Psych Society and from Hopkins and other organizations to do that. The one other thing I'd say is I think, we really try to strive for alignment with all these programs, but I think it's even more important on that one. We really should probably start talking with Medicaid from the very beginning, because so many of those items end up in Medicaid. So I think you're making a really good point. Obviously, also getting Optum to actually pay people would help with that as well too, but that's another issue for another call and above a lot of our pay grades. But
Agreed.
when you don't pay providers for things, amazingly, you don't get good service.
Yeah, I'd love to figure out how, that seems like something that would be really promising and really just bigger than just the behavioral health episode.
Yeah.
Yep. So I think, Nikki, I 100% agree with you, and I think it's definitely an area that needs a lot of attention and patience, where we could do a lot of good on. Jean, I don't know if you want us. We've been talking with some behavioral health providers and with Care First, which is developing a similar behavioral health specialty medical home. I don't know if you and Nikki want to convene some folks, and we'd be happy to participate, or whether you want us to take the lead.
Or maybe we should just mix the whole crew together instead of having separate conversations, just from an ease point of view. We all need to work together on it. So
yep.
Thanks.
I do just want to mention though that I think it's definitely an area where we could do a lot of good. We are encountering some data challenges here around 42 CFR Part 2, which prevents with limits the substance use disorder claims, and we have found makes it a little bit tricky to identify patients. We think we potentially have some ways around that, but there are more lawyers involved than I would like. So I do want to mention that as we start out on this process, so that we don't get too excited too quickly.
Well, a lot of times things that are good take a little bit of time.
Yep.
All right. Renee.
Hi, yeah, moving forward, I had a question about performance year 2023 and the baseline. Is the baseline going to continue to be 2019, but for new entities, it will be 2022?
So we're keeping the baseline at 2019 right now. I think in the future, we definitely need to assess the validity of using 2022 as a baseline period. That we are concerned that COVID has had some impact on episode costs. Specifically, if COVID has caused the episodes that trigger to become more severe, it may penalize participants when comparing them to baseline period episode costs. So we have to do some robustness to figure out when things are quote unquote back to normal. We're doing some of that analysis now, but even in 2022, although the rates of COVID tend to be a little bit lower, there still has been substantial service disruption and lower volumes within some of these areas and higher length of stays, which raises the question of whether or not we can adequately risk adjust. And so we are intending to keep it at 2019 for 2023, but we do need to come up with some solution for updating those baseline periods in the future, particularly since we currently do require that 75% of the equipped entity have some touch with the episodes in the baseline period, and we do recognize that will become increasingly difficult as we get farther and farther from 2019.
Right, because providers are moving around, and it's just what we've noticed is it's just significantly cost a lot more to provide care or to perform procedures, the materials, the supplies, everything. I mean, I'm not saying anything that anybody doesn't know, that everything across the board, it just costs a lot more money to do a procedure in 2022 than it did in 2019. And I just have to wonder if that inflationary factor was was enough.
Right. So we are doing some analysis as well, just to check to make sure that our inflation updates were sufficient, and we can update this group on the results of that analysis. In general, we do think the inflation update is sufficient. We are pulling them directly from CMS, right? And so that we use the inflation factors that go into actually setting the payments. We have done some robustness analysis to kick the tires there, and we'll share with this group once that analysis is complete.
Okay, thank you.
So I meant to bring this up when I started, but I forgot. I guess it's Friday before Thanksgiving, right? We're not as on our game as well. MedCai has been working very closely with the AMA, and there's a large coalition of folks trying to get the advanced payment model 5-point bonus extended. For those of you who don't remember this, one of the great features about Equip, because CMMI has given us credit for the risk the hospital takes in the total cost of care model, we meet the thresholds, and it is classified as an advanced payment model, which includes a 5-point bonus under MACRA. Right now, that bonus goes away at the end of the year on December 31st. The plan politically is to try to get it extended during the lame duck session in Congress. I was in contact with Senator Cardin's office last week and was told that they were cautiously optimistic that there was a shot at getting a 1-year extension. Obviously, we're asking for a longer extension or making it permanent, but the problem is that with all these measures, there are these arbitrary rules that can't cost too much money, and the score on this is very expensive, and that's why it's harder to get a more permanent fix. But for anybody on the call who has any influence, now is the time to talk to Van Hollen and Cardin and any other senator maybe for some reason, and congressman that but try to get that extension. Obviously, that's a really big benefit in being in this program, is that 5-point bump. It's something MedCai is very, very focused on. Obviously, the folks from the state don't take positions on things like this, so I don't want to put Will or Jessica in a bad position. But MedCai strongly supports extending it, and any help anybody could give, this is the time now. If we lose it, I do think that it will change the math on a lot of people's decision to participate in this program and other programs as well. So anything else for the good of the order? Will, Jessica, any other questions?
I don't think we have anything. If you do have additional questions, please feel free to reach out to us through the Chris Equip email address, and we'll get that question answered and triaged to the appropriate person. And if you have additional episode ideas, please reach out to me. We'd love to chat with you.
All right. Thank you, everyone.
Thank you. Happy Thanksgiving.